Hi there, I'm Autumn Sanderson, and this is video one of my gold standards for COPD exacerbations for respiratory 2480. In this video, we will be identifying COPD. Quick overview. In this presentation, we're going to talk about what COPD is, what are its causes, and how COPD is diagnosed. What is COPD? COPD stands for chronic obstructive pulmonary disease, and it's defined as a lung disease where we get narrow airways and an obstructive airflow and many breathing problems. This is a non-curable disease, so it is chronic, and it may be accompanied by various illnesses, symptoms, and or other complications. According to the World Health Organization, it is the fourth leading cause of death worldwide. And COPD can also be known as emphysema or chronic bronchitis. Common COPD symptoms include shortness of breath, an increased sputum production, wheezing. Especially when we listen to our lungs, you're gonna hear a lot of wheezing going on. Sometimes patients are so wheezy, however, you might even hear them without a stethoscope. They'll also have a pretty chronic cough. This comes along with that increased sputum production. Exacerbation, so these are going to be COPD flare-ups. Sometimes these flare-ups can be so severe that they cause hospitalizations with our patients. So as healthcare providers, one of our goals is to try to reduce or limit these exacerbations, and also a low SpO2. Some COPD patients might have oxygen sats around the upper 80s. Known causes of COPD, tobacco smoking is going to be one of our biggest and most commonly seen causes of COPD. In our higher income countries, we're going to see about 70% of our COPD patients have it because of smoking, whereas in our lower to middle class countries, it's going to be more so 30 to 40% of those patients who have COPD. Secondhand smoke, not as common as tobacco smoking, but it is definitely a known cause of COPD. Your household, occupational, and outdoor air pollution can contribute to a COPD diagnosis. This can include dust, fumes, fuel, smoke, and other chemicals. For example, if you are living in a household where coal is burned, you might get some of that smoke inhalation, and that might cause COPD. From an occupational standpoint, if you work in a mine, you're probably going to later in your life come down with a COPD diagnosis. Or if you live in an area, let's say where there is a lot of wildfires, that smoke can also contribute to COPD. Early life events can also be a cause of chronic obstructive pulmonary disorder. This can include a premature birth. If you have poor fetal development, your lungs were not fully developed while you were in utero, and frequent respiratory infections. So if you are somebody that grew up with chronic pneumonia, you might find that you later have COPD. Childhood asthma patients um, are also people who we find a lot of COPD patients to be. There's also a rare genetic disorder that kids can have called alpha 1 antitrypsin deficiency. In this disorder, kids come down with COPD, even though they may have never smoked before. And then also aging. Not everybody is going to develop COPD in their lifetime, but it is a known fact that as we age and get older, our lung function decreases and you could develop COPD. So, how is COPD diagnosed? Well, it should be suspected in patients who have any sort of symptoms of COPD. So any of those symptoms that we previously talked about: shortness of breath, increased sputum production, a chronic cough, those exacerbations, low SpO2, we have to assume that they might have COPD, especially if they have a smoking history. However, the gold standard is going to be a pulmonary function test or spirometry testing. This is going to confirm a COPD diagnosis. Other factors to consider when you're diagnosing COPD, other ways that can lead to a COPD diagnosis. We're going to look at the patient history. This is going to, again, include all of those possible causes why we might have COPD. Where have they lived? What was their occupation? Are they a smoker? Do they have any previous hospitalizations? What does that medical history sort of look like? A physical exam, of course. This is why it's so important that patients are going to their regular checkups. We're going to do a physical exam. We're going to listen to those lungs. We're going to get our vitals, see what's going on. Imaging, a chest x-ray can show us a couple things. One of the biggest things that it can tell us is if there is hyperinflation in the lungs. This is something that's really common with COPD patients. Sometimes that hyperinflation in the lungs is so bad that it actually causes a barrel chest feature. And then another sort of imaging that we can look at is a chest CT. And this is going to give us a little bit more information about how severe our COPD is. And then we can also get an arterial blood gas. So with a lot of our COPD patients, they're going to have higher CO2 levels. Some of them will even be chronic hypercapnic patients. So this ABG could tell us a lot as well. Also, with a lot of these factors that we're considering, even if a PFT or a spirometry test is indicating a COPD diagnosis, it's important that we look at all of these different factors because we might need to roll out some other possible causes like another lung infection. So like I said, PFT is the gold standard. A spirometry of an FEV1 or an FBC less than 0.7 post bronchodilator is required for a COPD diagnosis. As you can see that image there, we have our patient doing a spirometry test. The gold grades and severity of airflow obstruction. So we have a couple different levels that we're looking here as our list goes on from gold 1 to gold 2, gold 3, and gold 4. Our COPD patients' diagnosis goes from mild, moderate, severe to very severe. So if you're going to have a gold 1 grade, that's going to tell us that our severity level, we're mild, our FEV1 is greater than or equal to 80% of predicted. Gold 2 moderate, less than or equal to 50%, and FEV1 less than 80% of predicted. Gold 3, now we're getting a little bit more severe. We're going to have less than or equal to 30%, and our FEV1 is going to be less than 50% of predicted. And then gold 4, these are very severe COPD cases where our FEV1 is less than 30% of predicted. And then here is everything that I just explained again, but in chart form. Okay, so for this presentation in video 1, we talked about what COPD is, chronic obstructive pulmonary disorder and its symptoms, shortness of breath, a lower SpO2, a lot of sputum production, chronic cough, what causes it, your lifestyle, and are you a smoker? Do you have a smoking history? Do you have a history of chronic lung infections? Do you have any sort of factors within your household or around you that might be contributing to this disease? And diagnostics, so we talked about how we can diagnose COPD, assessing our patient, looking at imaging, and then of course the PFT, the gold standard, where we then went on to talk about our severity scale, which is the gold grades 1 through 4, 1 being mild, 4 being most severe. And there is my citations for video 1.